This presentation discusses blood glucose regulation in the human body, the normal physiology of this mechanism, the consequences of its failure, such as type 2 diabetes, the reasons for this failure, and the treatments available for type 2 diabetes. For this presentation, I have chosen metformin as my preferred treatment option. The body uses a complex feedback system to manage blood sugar. When glucose is low, the pancreas releases glucagon, which stimulates the liver to release glycogen. Glycogen is the liver's stored form of glucose. After eating, the pancreas releases insulin to reduce glucose levels. These mechanisms help maintain homeostasis. This picture illustrates examples of how the body regulates its internal environment. The internal environment is maintained at a relatively constant state through various mechanisms. It's important to note that homeostasis does not equate to equilibrium. Each body has its own balance that it maintains, and these states differ among systems. While blood glucose regulation may appear minor, in the grand scheme, it is crucial for the body's overall well-being. Usually, when we think about diabetes, we tend to think of the pancreas first. But what does the pancreas really do? The pancreas plays a dual role. It releases digestive enzymes and regulates blood sugar through hormones like insulin, glucagon, gastrin, and amylin. This illustration shows us that the pancreas has both exocrine and endocrine parts. The exocrine part makes digestive enzymes and bicarbonate, which are sent to the small intestine. The endocrine part releases hormones like insulin into the blood. Acinar cells make inactive enzymes to avoid self-digestion. In the small intestine, trypsinogen is activated to trypsin, which then activates other digestive enzymes. Duct cells produce bicarbonate to neutralize stomach acid, using carbonic anhydrase and chloride bicarbonate exchange system. Chloride leaves through CFTR channels. Bicarbonate enters the gut, and sodium and water follow through leaky junctions. Insulin is a peptide hormone made by beta cells. It helps cells absorb glucose from the blood. It's released after meals and works to lower blood sugar. The diagram shows how the body digests food and regulates blood glucose after a meal. When food enters the GI tract, it stretches the gut and introduces carbs, triggering stretch receptors and hormone release from the small intestine. These signals, along with parasympathetic output from the brain, stimulate pancreatic B cells to release insulin. Insulin helps the liver store glucose and promotes glucose uptake in muscle and fat cells, lowering blood glucose levels. As glucose drops, insulin release decreases, which is a negative feedback loop. Pancreatic A cells, which release glucagon to raise glucose, may also play a role. Glucagon is produced by alpha cells. It works opposite to insulin. When blood glucose is low, glucagon triggers the liver to release stored glucose. The diagram shows how the body keeps blood glucose levels stable using a negative feedback loop. After eating, high blood glucose triggers the pancreas to release insulin, which helps absorb glucose and stores extra in the liver as glycogen, lowering blood sugar. When blood glucose is low, such as during fasting or exercise, the pancreas releases glucagon, which signals the liver to release glucose by breaking down glycogen and making new glucose. This maintains a normal blood sugar level. As levels return to normal, insulin and glucagon release slow down. This balance keeps glucose in a healthy range for the brain and body. In a fed state, insulin activates GLUT4 transporters to move glucose into muscle and fat. In fasting, GLUT2 transporters help release glucose from the liver. The diagram shows how glucose transport changes between the fasted and fed states in muscle, fat, and liver cells. In muscle and fat cells, no insulin in the fasted state means GLUT4 transporters stay inside the cell, so glucose can't enter. After eating, insulin causes GLUT4 to move to the membrane, allowing glucose in. In liver cells during fasting, glucose is made and released into the blood by GLUT2 transporters. After eating, high glucose and insulin levels reverse the gradient. So glucose enters the liver through GLUT2 and is stored as glycogen. The liver switches between releasing and storing glucose depending on the body's needs. This ratio shifts depending on whether you're fed or fasting. After meals, insulin dominates. In fasting, glucagon takes over to maintain a normal level of blood sugar. This diagram shows how insulin to glucagon ratio controls metabolism in fed and fasted states. After a meal, rising blood glucose triggers insulin release, which promotes glucose uptake and the storage of glucose, fat, and protein. Glucagon is suppressed. During fasting, low glucose leads to glucagon release, which promotes glucose production and ketone formation, while insulin stays low. After eating, glucose and insulin levels rise and then fall, while glucagon drops and later rises again. This balance keeps blood glucose steady to supply energy to the body. The body uses feedback loops. High blood sugar equals insulin from the pancreas to lower it. Low blood sugar equals glucagon from the liver to raise it. This maintains a stable internal environment. The picture shows how the body regulates blood glucose through a negative feedback loop. After eating, blood glucose rises, triggering the pancreas to release insulin. Insulin helps cells absorb glucose and signals the liver to store it as glycogen, lowering blood sugar. When blood glucose drops too low, the pancreas releases glucagon, which tells the liver to break down glycogen and release glucose into the blood. This cycle keeps blood sugar levels stable. High insulin promotes glucose storage, while glucagon raises the blood sugar by converting glycogen to glucose. This is the breakdown of glycogen into glucose. It occurs in the liver and muscles and helps raise blood glucose in response to glucagon and stress hormones. The diagram shows glycogenolysis, the breakdown of glycogen into glucose. In muscles and liver, glycogen is broken down by glycogen phosphorylase into glucose 1-phosphate. Debranching enzymes help remove glycogen's branches, allowing further breakdown. Phosphoglutamate converts glucose 1-phosphate to glucose 6-phosphate, which in the liver is turned into glucose by glucose 6-phosphatase and released into the blood. In muscles, glucose 6-phosphate enters glycolysis for energy. Glucagon, epinephrine, and norepinephrine regulate this process. This illustration shows gluconeogenesis, the process of creating glucose from non-carbohydrate sources like pyruvate, lactate, glycerol, and amino acids. This mostly happens in the liver and kidneys. Pyruvate, lactate, amino acids, and glycerol provide the carbon needed for glucose synthesis. The process leads to glucose 6-phosphate, which is converted into glucose, the final product released into the blood to maintain blood sugar levels. Gluconeogenesis happens in the liver during fasting, low-carb diets, or during periods of starvation to maintain glucose levels when the body has to utilize non-carbohydrate sources of energy. Type 2 diabetes mellitus. This is a condition where the body can't use insulin effectively. Blood sugar stays high. Over time, this can damage organs and tissues. When blood glucose is high long-term and cells are damaged where insulin is utilized, this leads to insulin resistance. Insulin resistance is what leads to full-blown type 2 diabetes. There are several signs and symptoms of type 2 diabetes that include thirst, frequent urination, hunger, blurred vision, fatigue, slow healing wounds, and along with others listed here. Some people show no symptoms at all or even notice that something is off. One common diagnostic test for diabetes is the A1C test. This test measures a person's average blood glucose levels over the past 2 to 3 months. It works by detecting the amount of glucose that has attached to hemoglobin, the protein in red blood cells. Since red blood cells live for about 3 months, the A1C test provides a reliable picture of long-term blood sugar control. An A1C level below 5.7% is considered within normal range. This is a fasting blood test. It's an accurate way to measure what the body's doing in a fasted state, when the patient hasn't had anything to eat for at least 8 hours. Out-of-range blood glucose that is elevated while fasting can indicate that the body is not controlling glucose levels effectively. So the oral glucose tolerance test, or OGTT, is probably best known as the test pregnant women take to check for gestational diabetes. But it's also really important for patients with cystic fibrosis. And here's why. In people with cystic fibrosis, the A1C test isn't always accurate. That's because cystic fibrosis can cause malnutrition and changes in red blood cell turnover, which can make A1C levels appear lower than they really are. So instead, we use the OGTT to get a better picture of how the body handles glucose. The test itself involves 3 blood draws. One when the patient is fasting, another 30 minutes after drinking the glucose solution, and a final one 2 hours later. We're looking to see how the body responds to the glucose. Ideally, blood sugar should rise after the drink and then drop back down to normal within 2 hours. If that doesn't happen, it might mean there's a problem with how the body is processing glucose, and that could lead to a retest or an additional follow-up. This blood test is just checking a patient's blood sugar as it says at random. This is less commonly used as a first-line diagnostic test. When it is at random, many factors can alter the results, making them seem high or low. However, this test can reveal that further blood testing may be needed. Here are the ranges for each of the tests I just spoke about. These levels usually indicate diabetes. An A1C greater than or equal to 6.5%, a fasting glucose level greater than or equal to 126 milligrams per deciliter, or an OGTT greater than or equal to 200 milligrams per deciliter. Even when these levels are found, these must be confirmed with repeated tests. The most well-known subtypes are type 1 diabetes, type 2 diabetes, and gestational diabetes. This diagram helps us understand the key difference between normal blood sugar control, type 1 diabetes, and type 2 diabetes. On the left, in a normal situation, the pancreas releases insulin, shown as pink dots. The insulin acts like a key, unlocking the doors, which are the insulin receptors, on our cells, allowing glucose, shown as blue squares, to enter and provide energy. In the middle, we see type 1 diabetes. Here, the pancreas isn't producing much or any insulin, indicated by the red X over the insulin. Without this key, the glucose can't get into the cells, leading to high blood sugar levels. On the right is type 2 diabetes. In this case, the pancreas is still making insulin. However, the problem is that the cells have become resistant to the insulin, as shown by the red X blocking the glucose from entering even when insulin is present. So even though there's insulin around, the cells don't respond to it properly, and glucose builds up in the blood, causing elevated blood sugar. More recently, studies have been able to narrow down these subtypes even further, grouping individuals who have similar insulin resistance and/or deficiency, body types, or other similar characteristics. These include MOD, MARD, SAID, SIDD, and SIRD. They vary in cause, severity, and response to treatment. Conditions like obesity, infections, steroid use, or genetic disorders may mimic diabetes symptoms. These conditions can also contribute to type 2 diabetes and make it worse. Type 2 diabetes can worsen over time if not appropriately diagnosed and controlled. Treatment may start with diet and exercise, but often requires medication. Prevention is key to avoiding this damage. Poorly managed diabetes leads to long-term damage to several different body systems. So how common is this disease? Well, let's start with prediabetes. Did you know that 1 in 3 adults have prediabetes? That's a huge number. What's even more surprising is that 8 out of 10 people with prediabetes don't even know they have it. When we look at diabetes as a whole, around 90 to 95% of Americans who have diabetes are living with type 2 diabetes. And this isn't just a national issue, it's global. About 6.3% of people worldwide have type 2 diabetes. So clearly this isn't rare. It's incredibly common, and a lot of people don't even know they're at risk. Prevalence is higher among older adults above the age of 45 and several ethnic minorities. Let's go over who's at greater risk for developing type 2 diabetes. First, being overweight or obese is one of the biggest risk factors. Age is another. If you're 45 or older, your risk starts to go up. Family history plays a role too. If someone in your immediate family has type 2 diabetes, your chances increase. Certain racial and ethnic groups are also at higher risk, including African Americans, American Indians, Asian Americans, Hispanics, Latinos, and Pacific Islanders. A sedentary lifestyle, meaning not getting much physical activity, also raises your risk. Tobacco use or even just regular exposure to secondhand smoke can contribute as well. If you've been diagnosed with prediabetes, that's a major warning sign. And finally, for women, if you have gestational diabetes during pregnancy, that increases your risk for developing type 2 later on. These next few slides will explain what happens in the body with type 2 diabetes. These pictures show what it may look like at the cellular level in the pancreas and liver. Over time, when there's too much sugar in the blood, what we call chronic hyperglycemia, the cells in your liver, muscles, and fat stop responding properly to insulin. This is called insulin resistance. To try and keep up, the pancreas starts pumping out more and more insulin, but eventually the beta cells in the pancreas, the ones that make the insulin, get overworked. They can't keep up with the demand, and they start to shrink and wear out. That's when blood sugar levels start to climb, and managing diabetes becomes much harder. This comic shows a cartoon pancreas being alerted that high blood glucose has been detected. The pancreas then starts to work really hard to release more insulin. As you can see at the end, the body does not respond and actually rejects the insulin produced and released. Furthermore, when the pancreas is constantly working to produce these high amounts of insulin, it becomes overworked. And the beta cells that produce the insulin can't keep up with the high demand. But as you can see in this comic, the cells aren't going to accept it anyway. Meanwhile, here's more on the liver. When the body can't use glucose properly, like in uncontrolled diabetes, it starts to store the extra sugar as fat. It does this by converting glucose into triglycerides, which gets stored in the fat and liver tissue. Meanwhile, the liver's glycogen stores, which normally act as a backup energy source, start to run low because glucose isn't being absorbed or turned into glycogen like it should be. So when the body needs energy but can't get it from glucose, it starts breaking down fat instead. And when that happens, the liver produces something called ketones. These ketones get released into the bloodstream, and in small amounts, that's okay. But if too many ketones build up, they can make the blood too acidic, leading to diabetic ketoacidosis. When blood sugar stays high for too long, it starts to damage the blood vessel, and that can cause problems all over the body. In the eyes, it can lead to vision problems or even blindness. This is known as diabetic retinopathy. In the ears, high blood sugar can damage small blood vessels and contribute to hearing loss over time. It also puts a lot of stress on the heart and brain, increasing the risk of heart attacks, strokes, and high blood pressure. The kidneys are especially vulnerable. Over time, they can stop working properly, and in severe cases, a person might need dialysis. The arms, legs, hands, and feet can be affected too. Poor circulation may lead to numbness, tingling, pain, and slow healing wounds. In the worst cases, it can lead to infections and even amputations. And even the skin can suffer. People with diabetes are more likely to deal with dryness, irritation, and infections. So it's not just about keeping your blood sugar in check, it's about protecting your whole body. So this is the pathophysiology in a nutshell of type 2 diabetes. It usually starts when your blood sugar levels stay too high for too long. Over time, your cells, especially the muscles, liver, and fat tissue, just stop responding to insulin the way they should. That's why we call it insulin resistance. When that happens, those cells can't absorb glucose properly, so they can't use it for energy. And when the body can't get energy from glucose, it starts trying to burn fat instead. Now, that might sound okay, but that only really works in the short term. It's not a healthy or sustainable fix. There's also something interesting that researchers have found. Visceral fat, which is the fat stored deep around our organs, seem to play a role in this. That type of fat actually releases a protein called RBP4, and that protein has been shown to increase insulin resistance even more. Again, if type 2 diabetes isn't managed over time, it can cause serious complications. Some of the most common ones include heart disease and other cardiovascular problems, nerve damage, kidney damage, and eye problems. A patient with type 2 diabetes might present with all or some of these symptoms. A lot of these can show up gradually, and people may not even realize that they're connected. First, there's the increased thirst and more frequent urination. That happens because the kidneys are working overtime trying to get rid of all the extra sugar in the blood. You might also feel hungrier than usual even after eating. That's because the body isn't using glucose properly for energy, so it keeps sending hunger signals. Unexplained weight loss can happen too. Since the body can't use glucose, it starts breaking down fat and muscle for fuel. A lot of people also feel really tired or worn out just from the lack of usable energy. You might notice blurred vision. High blood sugar can temporarily mess with the lenses in your eye. Cuts or wounds might take longer to heal, and you could get infections more often. This is because high blood sugar weakens the immune system and affects circulation. Some people experience numbness or tingling in the hands and feet. That's a sign of nerve damage from long-term high blood sugar. And one more that not everyone talks about, dark patches of skin, usually on the neck, underarms, and groin. And that's caused by high insulin levels affecting how the skin cells grow. One of the treatments is metformin. Metformin reduces liver glucose production and improves insulin sensitivity in the muscles. It's often a first-line treatment. The side effects are mild and usually GI related. This is my choice for treatment of type 2 diabetes, and I will discuss this treatment in more detail shortly. Another treatment is DPP4 inhibitors. These keep GLP-1 and GIP active longer, improving blood sugar control without causing weight gain or causing blood sugar to drop too low. There are a few FDA-approved versions, and they have been shown to work for colorectal cancer and complications related to COVID-19 off-label. Another treatment is the GLP-1 and GIP antagonists. These are all over social media right now and the news. These medications are designed to resist being broken down by an enzyme in the body called DPP4. So they stay active longer and help regulate blood sugar more effectively. They work by helping the body release insulin when it's needed and reducing the amount of sugar the liver releases. which helps lower blood glucose levels. Some of these medications also promote weight loss, which is a big benefit for many people with type 2 diabetes. On top of that, certain types have been shown to lower the risk of heart disease, which is especially important since people with diabetes are at higher risk for heart-related problems. There are several FDA-approved versions of this type of treatment. However, there are also several that come from compound pharmacies and they are not FDA-approved. This is due to many inconsistencies in the production and accuracy of the dose. Off-label, it can be used just as a weight loss medication in patients who don't have insulin resistance. SGLT2 inhibitors work by targeting the sodium glucose cotransporter 2 protein in your kidneys. Furthermore, clinical observations and studies have indicated that SGLT2 inhibitors are often associated with weight loss and lower blood pressure. There are also proven cardiovascular and renal benefits in individuals with pre-existing heart disease, kidney disease, and heart failure. This can make this treatment a preferred choice for patients with pre-existing heart and kidney conditions. Off-label, it can be used to help treat low white blood cell counts in patients with type 1 diabetes. Sulfonylureas stimulate the pancreas to release more insulin. These can be effective but may cause hypoglycemia and weight gain. Off-label, it has been used to treat neonatal diabetes. Thiazolidine ions improve insulin sensitivity in muscle and fat. There's also a lower risk of hypoglycemia, but it may cause fluid retention. Patients also have increased risk of heart failure. Off-label, one version of this medication, pioglitazone, has been used to help patients with PCOS, and it can reduce the risk of some cardiovascular problems in diabetics. Back to metformin. This medication belongs to a class called biguanides, and it's the only medicine in that specific group. You may know it by its name, glucophage. Clinically, metformin is the go-to first-line treatment for type 2 diabetes in both adults and kids who are 10 years and older. It's typically prescribed when just making changes to your lifestyle, like diet and exercise, isn't enough to manage blood sugar. Now, the American Diabetes Association, or ADA, has some guidelines for using metformin. If someone's HbA1c, that's a measure of average blood sugar, is below 9%, doctors usually start with just metformin alone. But if the HbA1c is 9% or higher, metformin is often used along with other therapies. It's really important to note that metformin is not used for treating type 1 diabetes. Metformin's mechanism of action helps to reduce the amount of glucose or sugar that your body absorbs from the food and drinks you consume. So the less sugar that gets into your bloodstream from your meals. Metformin also decreases the amount of glucose produced by your liver. Your liver can make sugar on its own, and metformin helps to put the brakes on this process, which also contributes to lower blood sugar levels. Metformin also does some of the other helpful things, like improving insulin sensitivity in your muscle tissue. Think of it as making your muscles more receptive to insulin, allowing them to use the glucose in your blood more effectively for energy. Metformin primarily works on glucose production and absorption, and it improves how your body uses the insulin it already makes. Now, let's zoom in on metformin's cellular action. It primarily activates AMPK, our cellular energy regulator, which triggers many benefits. It also inhibits mitochondrial respiration, which slightly slows energy production in the liver to reduce glucose output. Beyond that, metformin influences lysosomal function for cellular waste management and the GLP-1 pathway, impacting appetite and insulin. New research suggests that it might even activate AMPK through PEN2. a transmembrane protein found in various cell types all over the body. Looking at the diagram, metformin slightly reduces glucose absorption in the intestines. It boosts the release of GLP-1, which is a helpful gut hormone, alters gut bacteria, which contributes to blood sugar control. Specific proteins in intestinal lining help metformin get absorbed effectively, and studies also suggest that it reduces inflammation, helping the immune system. So, metformin works in multiple ways at the cellular level, impacting energy, glucose handling, gut signals, and potentially even immunity, all to effectively manage type 2 diabetes. So, why metformin is as a go-to treatment for type 2 diabetes? There are several key reasons. First, it has a proven track record of safety. We know a lot about it, and it's generally well tolerated. Second, it's effective at lowering A1C, which is a measure of your average blood sugar over time. Thirdly, it's generally affordable, making it accessible for many people. It also has broad availability, meaning it's widely accessible in pharmacies. And importantly, metformin offers a variety of other health benefits, such as potentially lowering blood pressure and reducing the risk of heart disease. Because of these advantages, metformin is often preferred over older, less expensive medications like sulfonylureas and thiazidinediones due to its better safety profile. This also holds true when comparing it to newer injectable medications like semaglutide. Even with all of this said, it's not the end-all be-all to treatment. Patients may still need to take supplemental insulin or additional medications to manage their type 2 diabetes. Let's quickly summarize what we've covered. Our bodies tightly control blood sugar by using insulin and glucagon as a balancing act. After eating, insulin lowers blood sugar by helping cells take it up. And the liver stores extra as glycogen. When fasting, glucagon raises blood sugar by releasing stored glucose and making new glucose in the liver. Type 2 diabetes develops when the body becomes resistant to insulin, leading to high blood sugar. Key risk factors include genetics, obesity, poor diet, inactivity, and smoking. Diagnosis is straightforward with a simple blood test. Managing type 2 diabetes involves various approaches, such as oral medications, injections, and crucial lifestyle changes like diet and exercise. Untreated, it can cause serious damage throughout the body. Importantly, many people who have type 2 diabetes have it without knowing, but it's often preventable. Common medications include metformin, GLP-1, and dual GLP-1/GIP receptor agonists, SGLT2 inhibitors, sulfonylureas, and TZDs. Metformin is often the first choice due to its safety, effectiveness, and affordability. It works by reducing blood sugar absorption from food and decreasing sugar production by the liver.